Okay, so today's topic, the actual topic is systemic manifestations of HIV and AIDS, including opportunistic infections, but we'll be talking in HIV in general. So we all know viruses are classified into RNA viruses and DNA viruses. Human immunodeficiency virus is one virus which is different from both because it is actually a RNA virus, but it behaves like a DNA virus. The reason for this is it has an enzyme called as RT or reverse transcriptase. So we know transcription is the process by which DNA gets converted to RNA. RNA gets converted to protein, that is called as translation. Whereas reverse transcription means RNA gets converted to DNA. So HIV is basically a RNA virus. With the enzyme help of the enzyme called reverse transcriptase, it gets converted to DNA. Humans also contain DNA. So the viral DNA can incorporate into the human DNA and it can produce some translation and post-translational changes, which we call as HIV infection or AIDS. So HIV is of two serological forms. One is HIV1 and HIV2. HIV1 is nearly worldwide form. HIV2 occurs in certain specific regions of the world like Africa. So another thing you have to, I think you can follow my pointer. Voice clear ah kekudha? Hello, கேக்குதா? பாதியில கட் ஆயிருச்சுன்னு நினைக்கிறேன். Am I audible now? Shall we proceed? There was some connection lost in between. Okay, so what I was telling was HIV1 and HIV2 are the two serotypes of human immunodeficiency virus. The envelope protein contains GP120 and GP41 together, which forms the stalk. Reverse transcriptase is coded by another gene from within the nucleocapsid. So what happens is, we all know CD4 is the receptor for the human immunodeficiency virus. So the spike protein or GP120-141 complex binds to the CD4 receptor, and this alone is not needed for the sorry again, I think I'll restart now because there were many interruptions in between. So human immunodeficiency virus is a RNA virus. It acts mainly through reverse transcriptase enzyme, by which the RNA becomes DNA. The DNA becomes incorporated into the human DNA and causes them pathological manifestations. The envelope protein of HIV-1 contains GP120 and GP41. These together form a spike. The spike binds to CD4 receptor in the human cells. Mainly it is present in the T cells. But along with this, we need something called as co-receptor stimulation, CCR5 and CXCR4. These two are the co-receptors. The presence of CD4 binding and CCR5 or CXCR4 binding is needed for entry. So once the virus enters, I told you the importance of reverse transcriptase enzyme. It converts the viral RNA into DNA. That DNA gets incorporated into the human DNA. And the human cell now it starts producing the viral particles. It gets packaged as goes for assembly and budding. So one important enzyme in this life cycle is reverse transcriptase. Another one is integrase. So for the virus to integrate into the human cell, we need another enzyme called as integrase. So that is what is mentioned as IN here. So two important enzymes are reverse transcriptase and integrase. Okay. So this is about the basic life cycle. HIV-1 is common. It is common worldwide, including India. Now the next thing we have to know is there are 4 clinical stages of HIV infection, starting from stage 1 to stage 4. There are 2 stages actually. One is WHO staging and another one is CDC staging. Remember anyone? This is a WHO staging. Stage 1 is asymptomatic patient, or he may have PGL. PGL is persistent generalized lymphadenopathy. I'll deal with this later also. Stage 2 contains some other infections. You can read this list later. The important ones are herpes zoster, oral ulcers, papillary pruritic eruptions, seborrheic dermatitis, nail infections, and recurrent respiratory tract infections. When you go to stage 3 and stage 4, it is even more important. Where stage 1 and stage 2 is called as early stage of infection, stage 3 and stage 4 is advanced. So you can have weight loss. More than 10% weight loss comes under stage 3. Chronic diarrhea is stage 3. Chronic fever is stage 3. Oral candidiasis, tuberculosis, oral hairy leukoplakia, and severe bacterial infections is stage 3. Stage 4 is a place where all tumors occur. So you would have learned in your pathology that there are few tumors which can occur in HIV infection, like anal tumors, Kaposi sarcoma, lymphomas. So all the tumors and all the CNS manifestation, esophageal candidiasis occurs in stage 4. So if you combine everything, you can get more than 20 or 30 infections here. But stage 1 is asymptomatic or persistent generalized lymphadenopathy. Stage 2 is less than 10% weight loss, mild respiratory infections, herpes zoster, and skin lesions. Stage 3 is all respiratory things, including severe weight loss and diarrhea. Stage 4 is HIV wasting syndrome and esophageal candidiasis, tumors, and CNS lesions. CNS lesions include HIV encephalopathy and CNS toxoplasmosis. Just a few words about diagnosis. So whenever an infection is there in the body, it produces antigens. Against antigens, we have antibody production. For virus, if there is a bacterial infection or a fungal infection, we can obviously culture the bacteria and find out the organisms. But for virus, culture is very difficult. It's a tedious process, taking a longer time. So the easiest one is either you can detect the antigen or you can detect the antibody or the proteins produced by the virus. These are 3 important things which we can do. So for HIV, the most easiest thing is we can detect the antibody. So the antibody is detected by a technique called as ELISA. Suppose in doubtful cases, we can detect antigen. We also have PCR testing available, or we can find out the protein which is produced, which is called as Western blot technique. I'm not going into the details. You can read the guidelines anywhere. The simplest technique is to find out the antibodies produced by the antigen. But antibody production for the viral antigen takes 120 days. This is 90 to 128 days. This is the window period where infection is present in the body, but antibody is not produced. Next question is whom all to test. First thing, if you are having a few, we'll be discussing the symptoms in the later part of our lecture. If a patient is having particular symptoms, like he's having an unexplained weight loss, more than 10%, or he's having a chronic diarrhea, or he's having esophageal candidiasis. So anything mentioned in the list, if the patient is having, obviously you have to do HIV testing. or a patient is coming to you because we don't know who is having HIV in the present era. So we have something called as opt-in and opt-out strategy. Any patient coming to your hospital, ideally they may have a HIV testing done, provided they are willing to do. So these are the two instances. One, if the clinical scenario warrants the HIV testing, he may be done. Or second thing, prior to blood screening, blood donation, everyone is tested for HIV. Prior to surgery, most of the people are tested. Or if the patient is willing, obviously, after a counseling, they may be tested. Antibody testing is done using a technique called as ELISA. It's of two types. We have a 2-test strategy and a 3-test strategy. Right? 3 test is, if the first test is positive, it is positive. If it is negative, you have to go for the second line of test, which will be a different test. It will not be an antibody test, it will be an antigen testing. Again, if it is doubtful, you have to go for the third step. So we have 2-stage testing and 3-stage testing. I'm not going to discuss them. In short, about the treatment regimen, I told you 2 important enzymes are present in HIV structure. One is the reverse transcriptase and integrase. The importance of knowing the structure is we have drugs which are targeted against these enzymes. So we have drugs acting against reverse transcriptase. They are called as reverse transcriptase inhibitors. It is of 2 types. One is nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, NRTAs, NNRTAs. We have some drugs called as integrase inhibitors. There are some newer drugs. We have dolutegravir, raltegravir, etc. Now, I forgot to mention about another enzyme, because in the later part we have packaging, assembly, etc. All these needs another enzyme called as protease. The drugs inhibiting this are called as protease inhibitors. So the classical drugs are nucleoside reverse transcriptase inhibitors. The examples of this are zidovudin, lamivudin, etc. Then we have some protease inhibitors, the drugs ending with vir, like ritonavir, etc., azatanavir, etc. They are some protease inhibitors. Non-nucleoside reverse transcriptase are efavirenz, nevirapine. Only 2 drugs, please remember them. And dolutegravir is the one which I told you, it's an integrase inhibitor. So if anyone asks you what are the drugs available for HIV, please classify them under the following headings and write. Tenofovir is also an NRTI, but the N here stands for nucleotide and it is not nucleoside. So nucleoside reverse transcriptase inhibitors include zidovudin, lamivudin, abacavir, etc. Nucleotide reverse transcriptase inhibitor is tenofovir. Protease inhibitor is nevirapine. Non-nucleoside reverse transcriptase inhibitor is nevirapine and efavirenz. Protease inhibitor is ritonavir, azatanavir, etc. And integrase inhibitor is dolutegravir. So what drug is given is, first line drug for adult is the first one given here. Please remember the dosage. It is TLD regimen. Tenofovir 300 mg, lamivudin 300 mg, dolutegravir 50 mg. It comes as a combination tablet. So 1 tablet per day, lifelong. Right? TLD, tenofovir, lamivudin, dolutegravir 300, 350. If you want the specific indication, it is people living with HIV/AIDS, age more than 10 years and weight more than 30 kg. Most people fall here. But weight is less than 30, just a small modification. Tenofovir is replaced by abacavir. At least the first 2 is enough for you. If the first line regimen fails, we have something called a second line regimens where the other drugs come. When do you say the treatment is failed is, there are 3 failures in HIV treatment. One is virological failure. That is, the viral RNA levels is still high despite treatment, is called as virological failure. Next is immunological failure. We all know, since the CD4 cells are infected by the virus, the CD4 cell is going to fall. So CD4 count has a very important role in the prognosis of HIV. So if the CD4 count is still low despite treatment, it is called as immunological failure. The third is clinical failure. We know very well that since HIV is an infection which affects the lymphocytes, patient is prone for all sorts of secondary infections. So preventing secondary infection or the so-called opportunistic infection is the important goal of treatment. So the patient is getting opportunistic infections despite ERT is called as a clinical failure. So we have started the TLD regimen. The patient's virological load is still high, we call it as a virological failure. The patient's CD4 count is still low, we call it as a immunological failure. Patient is getting opportunistic infections, we call it as a clinical failure. Another important is what's the indication to start ART. The ART is also called as HAART, highly active antiretroviral therapy. The guideline is simple. Previously, it was told that the low CD4 count should be started first, but now it is very simple. Any patient diagnosed as HIV, irrespective of the clinical staging, irrespective of the CD4 count, should be started an antiretroviral therapy. So the guideline is very simple. So who all to test? Patients with symptoms suggestive of any of the clinical staging of HIV, or the opt-in or opt-out strategy, or based on the physician's discretion, he is tested. Once he is tested positive, he has to be started an ART, irrespective of the clinical stage, irrespective of the CD4 count. How do you monitor? Monitor the RNA levels of the virus, monitor the CD4 count, monitor the clinical response. This is all about the basics of HIV. I think if this comes as an essay question, you can very well write 2 or 3 pages by this alone. Now coming to the most important thing and the most confusing thing, which is the actual topic of today, the systemic manifestations of HIV. Please remember, there are few infections in the body or few diseases in the body which can affect many systems. One thing is SLE. Another thing is tuberculosis, syphilis, and one among them being HIV infections. So these diseases, if they occur, they can affect any organ of the body. So if a particular system is producing a symptom, just a minute. Okay. So similarly, if there's a particular manifestation in a particular organ and patient is suspected to have HIV, it could be due to any of these reasons. The first thing and the most important you have to remember is it could be due to an opportunistic infection of HIV, or it could be an opportunistic cancer of HIV/AIDS. I mentioned earlier, lymphoma, Kaposi sarcoma, anal carcinoma, cervical cancer. These are the 4 tumors which can occur in HIV/AIDS. Or it could be a manifestation of the drug. So we have a wide spectrum of drugs: protease inhibitors, NRTA, NNRTA, integrase inhibitor. So many drugs cause many of the side effects. It could be one among them. Or finally, if none of these is proved, it could be due to the HIV infection itself. This will be the background of the entire class today. So we'll be dealing in parts. So what are the drugs and the reactions which can occur in a HIV patient? Any drug, for the first thing you have to remember is allergy or anaphylaxis. Allergy is very less common in HIV infection. Allergies can occur. Sorry, the allergies are very common, but the allergies won't be that severe enough to cause anaphylactic reactions. If you have to remember one drug which causes allergic and one drug which causes allergy or anaphylaxis, it is abacavir. Okay, abacavir. HLA B5701. Patients having this phenotype of HLA are more prone for anaphylaxis with abacavir. Once patient has an anaphylaxis, we should never give the drug again. But I told you allergy is very common. So just an allergy, we can give that. So minor skin allergies can occur. Severe skin allergies like erythroderma, Stevens-Johnson syndrome 10 can occur. Anaphylaxis is with only one drug, which is abacavir. Next thing, if you always remember a drug, we think of renal failure and hepatic failure. So these are the drugs which can cause renal failure. You may think, what are these drugs? Some of these drugs may be antiretroviral drugs. Some of these drugs are given for opportunistic infections. So pentamidine, amphotericin B. Amphotericin B is given for cryptococcosis, if you remember, and it is also given for mucormycosis. It is also an opportunistic infection in HIV. Cotrimoxazole can also cause renal failure, and some drugs cause renal calculi. Sulfadiazine, indinavir, azatanavir, and acyclovir. Indinavir, azatanavir are protease inhibitors. Some drugs cause hepatitis. I'll tell them later. Some drugs cause, most other drugs cause pancreatitis. Some drugs and steroids can cause osteonecrosis of the hip and shoulder. Some drugs can cause DVT. Zidovudin has a important, it's a peculiar side effect. It causes elongation of eyelashes and bluish discoloration of nails. So this is one category: allergies, renal changes, and hepatic changes. Another important Another important syndrome of drugs is immune reconstitution syndromes. If you remember the basic, HIV is an infection which is affecting the CD4 lymphocytes and reducing the CD4 count, thus causing infections. Once you are giving an ART, what has to occur is the CD4 count has to increase. Once CD4 count increases, it will start attacking all the infections which are present in the body, which is dangerous, right? So giving antiretroviral therapy can reactivate the immune system, which starts attacking the immune diseases, starts attacking the existing infections to cause some damage. This is one spectrum. We also know we have another category of diseases called as autoimmune diseases. So once our immunity gets activated, some autoimmune diseases can occur. So immune reconstitution syndromes can be a paradoxical worsening of an opportunistic infection, which is called as IRIS as such, immune reconstitution inflammatory syndrome, or it could be an activation of an autoimmune disease that is called as immune reconstitution disease. This IRIS is of two types, paradoxical IRIS and unmasking IRIS. For example, if you know that a particular person has an infection already, it is worsening, it is called as paradoxical IRIS. Unmasking IRIS is we don't know that the patient is having an opportunistic infection, but giving the drug is causing a manifestation. Right? So IRIS is of two types, paradoxical IRIS and unmasking IRIS. And immune reconstitution disease is the development of autoimmune disease. Together, IRIS and IRD are called as immune reconstitution syndromes. It's a very important question for you. When does it occur? It can occur within 2 weeks of starting antiretroviral therapy. It can come up to 2 years. If the first CD4 count is less than 15 per millimeter cube, it is very common. Why? Because more infections occur when the CD4 count is very low. It's a type of hypersensitivity. What are the symptoms? It's an immune reaction as such. So the patient will have fever, lymphadenitis, hepatitis, uveitis. So all infections can occur. You'll understand it when we discuss further. So the treatment of this is glucocorticoids plus antimicrobial. I told you infection is getting worsening. So we give the specific antimicrobial for the infection. Plus we are targeting the immunity, which is glucocorticoid. So people always tell you HIV is a condition where immunity is already low, so don't give steroids. But we can give steroids in HIV in specific indications, one among them being glucocorticoids. So next time someone talks to you about iris, don't think about the iris. This is called as iris flower in the image. Think of immune reconstitution syndromes. So this is what I told you. Paradoxical worsening of an existing clinical condition or abrupt appearance of a new clinical finding or unmasking following starting antiretroviral therapy. It can occur 2 weeks to up to 2 years, common with CD4 count less than 50. It can be fatal. Okay, so one category is due to the drugs, allergies, systemic manifestations, and iris. The last one I told you is once you are ruled out opportunistic infections and cancers, once you are ruled out drug infections in HIV, you have to think of manifestations due to HIV itself. So this can be a 2 marks question for you. In lung, it causes interstitial lung disease. You know very well, infections in the lung is classified into lobar pneumonia, bronchopneumonia, interstitial pneumonia, etc. Viruses usually cause interstitial pneumonia. So HIV being a virus, it causes interstitial lung disease. That's all. Just remember like that. Pulmonary arterial hypertension can occur in the lung. AIDS cholangiopathy. AIDS does not cause hepatitis as such, but it can cause obstructive jaundice. It is called AIDS cholangiopathy. HIV can cause diarrhea. It is called HIV enteropathy. HIV can affect the brain. Remember, if you read the pathogenesis of HIV, 2 important organ systems are affected by HIV as such. One is lymphoid system. The second one is neurological system. So the lymphoid system is the reason for all the immune reconstitution or infections we discussed. So another important thing is the neurological system. That is why we have, if the brain is affected, we can have dementia, AIDS dementia complex. If the spinal cord is affected, we call it HIV myelopathy. If the nerve is affected, it is HIV neuroradiculopathy. If the muscle is affected, it is HIV myopathy. This entire syndrome is a neurological syndrome. HIV can affect the heart. It's called HIV cardiomyopathy. HIV can affect the kidney. It is called HIV associated nephropathy. It can affect the bones, arthropathy. And remember one thing, atherosclerotic cardiovascular disease. The presence of HIV worsens atherosclerotic disease. So the patient can have stroke, MI, peripheral arterial disease, etc. earlier. So these are the diseases causing HIV. Again, if you remember from your basic days, you would have heard of a term called as AIDS defining illness. Right? If you don't remember that, I have been mentioning about the 4 cancers in HIV. So the 4 HIV cancers are one of the age-defining illness. That is, if this particular manifestation is present, it is definitely HIV. Like mucormycosis is a manifestation of severe diabetes. Presence of Kaposi sarcoma is an age-defining illness. So manifestations of HIV is different. It is different from age-defining illness. Okay. So why I have mentioned all these diseases? If the patient is presenting with HIV enteropathy, the treatment is treatment of AIDS. It is antiretroviral therapy. If you refer to textbooks, they'll be giving some 15 or 20 opportunistic infections, which will be very, very difficult to remember. So I have summarized them into system wise. So there are 4 age-defining illnesses in the respiratory system: recurrent bacterial pneumonia, tuberculosis, Pneumocystis pneumonia, and the very famous MAC, Mycobacterium avium intracellular complex. CNS, we have cryptococcosis, toxoplasmosis, Pml, and 2 non-infectious conditions: Hiv encephalopathy or the age dementia complex, and CNS lymphoma. GIT, we have 4: chronic HSV ulcers, oral ulcers, esophageal candidiasis. Remember, oral candidiasis is a stage 3 clinical disease in HIV, but it is not an age-defining illness. But esophageal candidiasis is an age-defining illness. Very often our chief asks this question: what are the manifestations of HIV? What are the manifestations of AIDS? Remember, esophageal candidiasis is an age-defining illness. Whereas just an early infection of HIV can cause oral candidiasis. Both are different. Similarly, chronic cryptosporidiosis, it also causes diarrhea. More than 1 month. Chronic isosporidiasis more than 1 month. So these 2 are stage 3 illnesses, if you remember. So chronic diarrhea due to cryptosporidiosis or isosporiasis, esophageal candidiasis, HSV oral ulcers. These are GAT age-defining illnesses. And other multi-system diseases: coccidioidomycosis, histoplasmosis, Kaposi sarcoma, recurrent salmonella septicemia, and HIV wasting syndrome. Some of these questions may be asked to you. So since we are attending in Zoom, only 40 minutes time is there. I'll close this session and I'll send another link so that in the next 40 minutes we can join. I'll send another link. Okay, we'll continue now. So this was the one which I was telling about age-defining illnesses system-wise. Another thing you have to mention about opportunistic infection is a particular opportunistic infection will occur only when the CD4 count falls below a particular level. So if the CD4 count is normal, that is, it is just in the range of 350 to 250, get predominantly skin infections. So if you remember, skin infections is stage 2 of clinical stage. So herpes simplex, herpes zoster, dermatophytic infections will be coming under the first set. Now, when it falls in the range of 250 to 150, we get another set, which is mainly of GIT manifestations and lung diseases: pulmonary tuberculosis, extrapulmonary tuberculosis, candidiasis, etc. When it falls even further, we get very severe infections like CMV retinitis, cryptococcal meningitis, PCP, recurrent bacterial pneumonia, etc. So remember this timeline. So coming to system wise, in upper respiratory tract, we have 2 mainly infections. One is sinusitis can occur, bronchitis can occur. Sinusitis, maxillary sinus is commonly involved. Remember the infections, say Haemophilus influenza and Streptococcus pneumonia. And similarly, regarding fungus, mucormycosis can occur. Lung is very, very important because we have 4 age-defining illnesses in the lung. One is recurrent bacterial pneumonia, tuberculosis, Pneumocystis carinii pneumonia, and Mycobacterium avium intracellular complex. You frequently would have come across these terms: Pneumocystis pneumonia and Mycobacterium avium. Apart from this, we can have fungal infections. And I told you, HIV infection as such can cause interstitial pneumonia. And the 2 tumors which can occur are Kaposi sarcoma and lymphoma. So we'll discuss each. Recurrent bacterial pneumonia, the same organisms causing sinusitis. Haemophilus influenza and Streptococcus pneumonia can occur. Apart from that, few cases of Staph aureus and Pseudomonas aeruginosa can occur. It can occur when the CD4 is in the range of 250 to 300. I told you just now. How will you treat pneumonia? I won't read every point. What is important, I'll just mention. So based on the organism, you have to treat. Streptococcus pneumonia, H influenzae, give third generation cephalosporin like ceftriaxone or cefotaxime. If it is more severe, you have to give a third generation cephalosporin plus a macrolide. If the patient is very critically ill or CD4 is less than 100, patient is having neutropenia, associated bronchiectasis or a suspected pseudomonas infection, you have to give a drug with a pseudomonas cover, which will be ceftazidime, cefepime. Again, third generation cephalosporins only, but ceftazidime and piptas are drugs which have pseudomonas cover, and meropenem. These are the drugs which we give for a normal pneumonia also, right? So patient is having a pneumonia, you give third generation cephalosporin. If it is severe, we give two drugs, third generation cephalosporin as an injection and macrolide as oral. Macrolide will be erythromycin or azithromycin, clarithromycin. If the patient is very severe, having suspected pseudomonas infection, we suspect pseudomonas infection whenever there's a bronchiectasis, neutropenia. So when these are there, we give ceftazidime, piptas and meropenem for 7 to 10 days. Okay, so one thing is recurrent bacterial pneumonia. The next is Pneumocystis pneumonia. This causes 25% of the pneumonia in HIV. Many of the infections occur in patients who are not even known to be HIV. So that's why it's an AIDS-defining illness. If the patient is having a pneumocystis pneumonia, think of HIV. This occurs if CD4 count is less than 200. The symptoms will be recurrent fever, night sweats, and unexplained weight loss. Remember these three symptoms: recurrent fever, night sweats, and unexplained weight loss. If you remember, these are the symptoms of tuberculosis also. Patient can also have dry cough and chest pain. The important thing is, if you do a chest X-ray, it will be normal. Mostly it will be normal, or you can have pleural effusion or interstitial pneumonia. Blood investigation, he will have elevated LDH. Since it's a lung infection, patient will have hypoxia and doing an arterial blood gas analysis. For people who don't know what is the capital A, small a O2 gradient, capital A is the alveolar oxygen concentration, small a is the arterial oxygen concentration. If there's some lung infection, the alveolar oxygen cannot enter the artery. So there will be an increased alveolar arterial oxygen difference or gradient, if you know. So how will you diagnose it? Do a histology or a PCR of the induced sputum, or if sputum is not able to be produced, we can do a bronchoalveolar lavage by a bronchoscopy, or we can do a transbronchial lung biopsy or an open lung biopsy. We have some extra pulmonary manifestations also. It can affect the external auditory canal, choroid lesions can occur, vasculitis can occur, bone marrow hypoplasia can occur, intestinal obstruction can occur. It can cause a cystic or calcified lesion in any organ. The most important thing is treatment. Cotrimoxazole. Cotrimoxazole is a combination of trimethoprim and sulfamethoxazole. The combination comes as 80 milligram of trimethoprim and sulfamethoxazole comes as 400 milligrams. So the total tablet is 480 milligram. 960 milligram tablet is called as double strength tablet. So a double strength tablet twice daily for 21 days is the treatment of choice for pneumocystis pneumonia. Very easy. Cotrimoxazole double strength tablet twice daily for 21 days. Suppose if there is a severe infection, when do you say severe? AA gradient is more than 35 millimeters of mercury, or patient is having hypoxia less than 77 millimeters of mercury, we have to give steroids. Steroid dose you all know very well, prednisolone 40 milligram BD for 5 days. Then you have to taper it, 40 milligram OD for 5 days, 20 milligram OD for the next 5 days. Cotrimoxazole has few side effects, like it can cause skin rashes, as I mentioned earlier. It can also cause bone marrow suppression. So any patient having allergy to cotrimoxazole, the alternative will be dapsone. Just remember this thing. So cotrimoxazole 960 milligram BD for 21 days is the treatment. Allergy to dapsone, allergy to cotrimoxazole, you give dapsone. It should be followed by secondary prophylaxis. Secondary prophylaxis will be lifelong. Okay, so recurrent bacterial pneumonia is over. Pneumocystis carinii pneumonia is over. The most important thing is double pandemic or TB and HIV. I always tell this: any patient with TB should be tested for HIV. Any patient with HIV should be tested for TB, because TB increases the chance of getting HIV. TB worsens the clinical course of HIV. Similarly, HIV worsens the clinical course of TB. HIV increases the chance of having TB. You can have it in any combination. But any patient with HIV, always think of TB. Any patient with TB, think of HIV. This patient also can have a normal chest X-ray. He can have a pleural effusion, lymphadenopathy, interstitial shadowing, etc. And it can occur even early in the course of infection. Even with CD4 count more than 250, it can occur. Here also the same 4 symptoms I mentioned. Weight loss. This is the 4 symptom screening tool. Prolonged cough, night sweats, weight loss, and fever. I will tell the importance of these 4 symptoms again. So again, TB, HIV, always go together. Any patient having one, please check the other thing. Knowing tuberculosis is very important because we know very well that the 2 important things are there. First thing is rifampicin is a drug which induces the metabolism of the other drugs. So if you are giving rifampicin plus ART, there may be some drug interactions. That is one thing. Second thing, the problem of virus. If you are giving antiretroviral therapy in a patient who is having a tuberculosis, immune reconstitution can occur and it can affect the lung even further. So that is why always you have to treat the opportunistic infection. You have to treat tuberculosis for at least 2 weeks, and then only we have to start on antiretroviral therapy. So coming to the last AIDS-defining illness in the lung, Mycobacterium avium complex. So MAC occurs with CD4 count less than 50 millimeters of mercury. The same symptoms again: fever, weight loss, night sweats. Apart from that, we can have diarrhea and lymphadenopathy. Just again, it can show normal or alveolar interstitial opacities. Here there will be anemia and elevated alkaline phosphatase. Remember, in Pneumocystis carne, there will be elevated LDH, I told you. Here there will be elevated alkaline phosphatase. Here again, you can demonstrate the infection by sputum positivity. I can do a bone marrow also. The treatment here will be clarithromycin, ethambutol, and rifampicin, cipro or amikacin. Usually we give amikacin. The clarithromycin, ethambutol, amikacin. For this, lifelong treatment is needed. So why I was always telling about the syndrome of fever is, in a patient with HIV, anyone coming with fever, night sweats, or weight loss, always think of a lung infection, right? The lung infections commonly encountered are tuberculosis, Pneumocystis carne pneumonia, and Mycobacterium avium complex. The thing is, if you're taking X-ray to diagnose, usually we look for cavities in the lung or consolidation in the lung to diagnose a tuberculosis. But in a HIV patient, if you're taking a chest X-ray, it may or may not show the symptoms. Just a pleural effusion may be present, or just an interstitial shadowing may be present. So any HIV patient with fever, weight loss, night sweats, these 4 symptoms are present means always consider some lung infection and try to prove the lung infection. If tuberculosis proved by sputum positivity, you are going to treat with anti-tubercular therapy. After TB, after starting ATT for 2 weeks, you have to start antiretroviral therapy. Whereas if you are suspecting PCP pneumonia, I told you Cotrimoxazole is the treatment of choice. That is what is summarized in this entire slide. Okay, I won't read about this slide. So other fungal infections can occur: Rhodococcus, pulmonary cryptococcosis, coccidioidosis, aspergillosis, histoplasmosis. So finishing our opportunistic infections of the lung, I told you next to consider manifestations caused by HIV itself. I told you interstitial pneumonia can occur. It could be lymphocytic interstitial pneumonia, non-specific interstitial pneumonia, or HIV pulmonary arterial hypertension. Lymphocytic interstitial pneumonia occurs in children. Non-specific interstitial pneumonia occurs in adults usually. You may always have a question. HIV is an infection which is reducing lymphocyte count, but how come lymphocytes infiltrate the lung? Remember, in the early stage of infection, lymphocytes will try to get activated to counteract this viral infection, but it fails in the later stages. So in the early stages of infection, lymphocytes will be activated. So it could be due to polyclonal lymphocyte activation due to HIV or due to EBV itself in lymphocytic pneumonia. NSIP is also the same thing, lymphocytic infiltration of the interstitium, but it usually occurs in adults. Whenever you hear the term pulmonary arterial hypertension, I always say the onset of pulmonary hypertension is the beginning of the end of the patient, right? So if you have studied pulmonary hypertension, there are 5 groups of pulmonary hypertension. Group 1 pulmonary hypertension is called as pulmonary arterial hypertension or primary pulmonary hypertension. It is usually a genetic cause, caused by PMPR2A mutation, if you remember. Group 2 pulmonary hypertension is pulmonary hypertension which is caused by a cardiac disease. So the patient with mitral stenosis or mitral regurgitation, in the long run, he may develop pulmonary hypertension. Group 3 pulmonary hypertension is pulmonary hypertension caused by lung disease. Usually 3 lung diseases commonly cause it: bronchiectasis, COPD, interstitial lung disease. And if you have to include one more, think of obstructive sleep apnea. So these are the 4 lung or airway diseases which can cause pulmonary hypertension. This is group 3 pulmonary hypertension. Group 4 is very important. It is called CTEPH, chronic thromboembolic pulmonary hypertension. So chronic pulmonary embolism will cause group 4. Group 5 is mixed. Whatever be it, whenever a patient is having a pulmonary hypertension, it is the beginning of the end of the patient. It was the norm previously, because once pulmonary hypertension occurs, definitely is going to die in some time. See, here also they are given mean survival is 2 years. But now treatment is advanced, so we can expect a even longer survival time. Now, since all these diseases are caused by the HIV itself, the treatment is only antiretroviral therapy and nothing else. So this finishes the lung. Now coming to the next important system, which is the GIT. So GIT will come part by part. One is the oral cavity and oropharynx. Whenever you are dealing with oral cavity and HIV, think of 3 things. Oral thrush can occur, oral hairy leukoplakia can occur, aphthous ulcer can occur. Oral thrush is due to Candida, oral hairy leukoplakia is due to EBV, aphthous ulcer is due to tissue destruction, cytokine. How the cytokine is produced? The early lymphocytic activation. So thrush, we know it is a white cheesy lesion. It occurs in the gingival border initially, and then it occurs in the soft palate and posterior oropharynx. You can see the image where it has occurred. Whereas hairy leukoplakia, it is also white in color, but it is more frond-like lesion in the lateral border of the tongue and buccal mucosa. You can see the location. So the same white lesion, if it is occurring in the tongue, oropharynx, it is thrush. If it is occurring in the lateral border of the tongue and in the buccal mucosa, it is called as oral hairy leukoplakia due to EBV. The treatment is different. Oral thrush is treated with clotrimazole. It is not cotrimoxazole. It is clotrimazole mouthwash 5 times a day for 2 weeks. And one of the antifungal drug is fluconazole, 100 to 200 milligram per day for 10 to 14 days. Oral hairy leukoplakia is a EBV infection. You know very well, EBV is nothing but human herpes virus 4. There are 8 herpes viruses. Herpes virus is a family of DNA virus. Any herpes virus infection, the treatment of choice is acyclovir or its family. Right? So oral acyclovir for 1 to 2 weeks, or we have a drug called as topical podophyllin retinoid. Aphthous ulcer is one given here. It's a broad-based ulcer, just a supportive treatment. You can give topical anesthetic, and since it is due to tissue destructive cytokine, steroids can be given here. So till now we have discussed 3 indications of steroids in HIV. One is iris, second is severe Pneumocystis pneumonia, third is oral aphthous ulcer. These 3 manifestations are markers of HIV. So presence of oral thrush, oral hairy leukoplakia, and aphthous ulcer means patient is having HIV. And it also indicates that patient is going to progress into an AIDS. 60% of the patients with these manifestations progress to AIDS within 1 year. Okay, oral cavity is over. Now come to esophagus and stomach. The same thing. The opportunistic infection which can occur are Candida, CMV, HSV, and aphthous ulcer. So you know very well, any esophageal lesion is going to cause dysphagia. So a patient with HIV presenting with difficulty in swallowing, 3 infections and 1 more possibilities there. Candidal infection, Candidal esophagitis. I told you it is a stage 4 clinical disease. So it presents as white cheesy lesions on endoscopy. Treatment is double dose of that of oral lesion. If oral candidiasis is present, we give 100 to 200 milligram per day. Here we give 200 to 400 milligram per day for 2 to 3 weeks. CMV is a human herpes virus 5. Here on endoscopy, you can get a single large ulcer. I'll comment on the treatment later. HSV will be a multiple small ulcer. But most of the time, we will not be able to do an endoscopy. So if any patient of HIV presenting with dysphagia, first to think of esophageal candidiasis. You can empirically treat them with fluconazole. This fluconazole also covers some amount of herpes simplex viruses. So even after giving fluconazole for 1 week, if the patient's dysphagia does not improve, you should think of CMV as a possibility, right? Because CMV responds to fluconazole plus acyclovir. Always remember, fluconazole should be the treatment for all the esophageal lesions, irrespective of the presence or absence of Candida, because Candida will invariably be present. So acyclovir dose will be 800 milligram per day for 10 days. Ganciclovir is a family of acyclovir again. Steroids may be used in distant cases. So 4th indication of steroid in HIV is esophagitis. In stomach, achlorhydria can occur. Okay. Small and large intestine. Intestinal lesion, obviously the manifestation is going to be a diarrhea. So So it could be due to a bacteria, it could be due to a protozoa, it could be due to a virus. Bacterial infection is going to invade the mucosa. So you are going to have abdominal pain, blood in the diarrhea. So bloody diarrhea is usually bacterial. A virus is not going to invade the tissue. So you are going to have a non-bloody diarrhea. But mucosal ulcerations can occur. I'll tell you later. Protozoal infection, please remember, diarrhea plus cholangitis, diarrhea plus malabsorption, always think of protozoal infections. So what are the bacteria which can cause diarrhea? Salmonella typhi, the one which causes typhoid, Salmonella typhimurium, Shigella flexneri, Campylobacter jejuni, and Mycobacterium avium complex. I told you one of the extra pulmonary manifestation of MAC infection is diarrhea. The protozoal infection, the three important protozoal infections are Cryptosporidia, Microspora, and Isospora belli. I told you cryptosporidiosis and isosporiasis for more than 1 month is an age-defining illness. It occurs in clinical stage 3. Viral infection, it is usually caused by CMV. Now CMV is going to cause ulcer of the mucosa, so secondary bacterial infection also can occur. For any bacteria, leukocytes is going to increase. So stool leukocytes, culture sensitivity will give a bacterial diagnosis. For protozoa, we can demonstrate oocyst in the stools. Some cases like microspora will need electron microscopy. We may need intestinal biopsy also. Virus cannot be diagnosed by any technique. We may need intestinal biopsy to demonstrate the intracellular inclusions. If it is bacterial, the treatment is easy. Erythromycin or ciprofloxacin. Protozoal infection. Protozoal infection, the treatment is ART itself. Apart from ART, nitazoxanide, albendazole, cotrimoxazole. So based on the organism, it varies. For example, cotrimoxazole acts on isospora. Albendazole acts on microspora. Nitazoxanide is the treatment for cryptosporidia. Virus, it is CMV. I told you acyclovir group, ganciclovir. For resistant case of acyclovir, we give foscarnet. Remember another drug. So CMV, it is acyclovir, ganciclovir, and foscarnet. Again, since protozoa is an age-defining illness, I have put it in separate slide. Cryptosporidium is small oocyst is seen. Right? If you are able to see, the treatment of choice for cryptosporidium is nitazoxanide 500 mg BD, azithromycin 500 mg OD for 5 days. Microspora responds to albendazole. Isospora is very easy to identify. It is a very, very large oocyst. The treatment of choice is cotrimoxazole. So cotrimoxazole has actions against many infectious agents. One was PCP, the other one is isospora. Here also the treatment of choice is one double strength tablet, but it is not BD, it is QID for 1 week. Remember Pneumocystis Pneumonia, I told you one double strength tablet BD for 5 days was the treatment of choice. Here we give one double strength tablet QID for 1 week, followed by BD for 3 weeks, followed by lifelong secondary prophylaxis. So the same thing is summarized here. Salmonella, Shigella, Mycobacterium avium complex, Campylobacter, all this are the bacteria. Protozoas, Cryptosporidium, Microspora, Isospora. Main thing. Apart from that, we can have entamoeba histolytic also. Viruses, any viruses can occur. CMV is typical. So this is a chart given in Harrison. How do you approach a HIV infection? Because once opportunistic infection is ruled out, we have an entity called as HIV enteropathy. Even HIV infection itself can cause diarrhea. So first, always ask a history and physical examination. Stool sample you are sending for culture because a culture can identify bacterial infection. You are sending for O1 parasites that can identify the parasites, isospora, microspora, etc. Always remember one sample is not diagnostic because obviously we cannot identify the infection very clearly in HIV infection and AIDS. So 3 samples are needed. So once there's a diarrhea, send a stool culture, stool O1 parasites for 3 samples. If all the 3 are negative, still we can consider any infection because treatment is more important. We'll come there. So if a diagnosis is attained by 3 samples, you treat the infection. If even after 3 samples you are not able to come to a diagnosis, then it's the indication to go for endoscopy and biopsy. If the biopsy reveals a diagnosis, treat it. If still an endoscopy or a colonoscopy and it does not reveal a biopsy, final diagnosis should be HIV associated enteropathy. The treatment of HIV associated enteropathy is ART as such. Clostridium difficile, since the patient is taking so many antibiotics, Prior history of antibiotic with diarrhea, always think of Clostridium difficile infection. That alone is enough now. But most of the time, we will not be able to isolate the organism. In that case, we may have to give an empirical treatment. The slide is taken from 2007 NACP guidelines, NACO guidelines for treating opportunistic infection. If the patient is sick, the patient is in hypertension, acute abdomen, or inability to drink, most of the time it will be due to a bacterial infection. So treat like salmonella by giving okay, follow my pointer. Give ceftriaxone 1 gram IV with metronidazole thrice daily for 14 days. Ceftriaxone covers bacteria. Metronidazole covers bacteria as well as few parasites, as well as hydration. Suppose if the patient is not that much sick, try to send for stool culture, stool O1 parasites for 3 samples. If you are able to treat isolate the organism, treat ASH. Right? Giardiasis, treat ASH with albendazole. Endemia histolytica, treat with albendazole. Suppose you are not able to isolate the organism, still it could be an infection also. So I'll treat empirically. I told you Cotrimoxazole covers isospora, so you can treat with that. Similarly, just erythromycin or Cotrimoxazole covers some bacteria also. So giving antibiotics more important. One antibiotic, if you have to remember, it is Cotrimoxazole. Okay. So we have finished GIT, we have finished lung. Hepatobiliary and pancreatic disease, it is very easy. Viral hepatitis. Whenever you think of hepatitis, think of hepatitis B, hepatitis C. Both are common in HIV. Right? To the extent that 90% of HIV patients have HBV co-infection, but patients may not have the disease. Because remember, hepatitis is a disease not due to the virus. Right? Hepatitis is not due to the virus. Hepatitis is due to the immunological response to the virus. So the presence of HBV is not going to cause hepatitis. The virus is going to stimulate an immune response, which damages the liver, which is going to cause hepatitis. Right? Now, since immunity is suppressed in HIV, patients will have HBV infection, but they will not have hepatitis. So up to 50% can have HCV virus, HDV virus, HEV virus. HCV's infection is severe in HIV. Granulomatous hepatitis can occur in HIV. Tuberculosis, fungal infections can occur. Coccidioidosis, histoplasmosis. I told you about, and cholangiopathy. Already I mentioned cryptosporidiosis, isospora cause diarrhea with cholangiopathy. Right? CMV can cause cholangiopathy. Kaposi sarcoma can cause cholangiopathy, and AIDS itself can cause cholangiopathy, as mentioned previously. The other important categories, drug-induced hepatitis and pancreatitis. So what are the drugs which can cause? Indinavir, azatanavir can cause just indirect hyperbilirubinemia elevation. Nevirapine can cause cholestatic hepatitis. Just know the names here, nothing much. Okay, coming to the next very important system, which is brain. The brain, already I told you, HIV infection itself is going to cause a change, which is called as HIV encephalopathy or AIDS dementia complex, which is an AIDS defining illness. It is classified into 3 stages. That is called as Frascati criteria. Just know the name, because if someone asks you HIV encephalopathy for a 2-mark question, you can obviously attend this one. Initial stage is called asymptomatic. Right? Next is called as mild neurocognitive disorder. The late stage is called as HAD, HIV Associated Dementia. So it's a big spectrum. Initially, it could be asymptomatic, where there is no impairment in daily activity. It could be mild neurocognitive disorder, where there is impairment in daily living. And the severe form is called HAD, HIV Associated Dementia. So the same thing I told you, it can occur in any stage of AIDS. So since CNS is the next important organ system which is affected by HIV, most of the patients will have it. It is a kind of subcortical dementia. Dementia is patient is going to lose his higher function. So what higher functions are going to be affected is memory and executive function are going to affect. Memory and executive function. Other symptoms like ataxia can occur, bladder and bowel disturbance can occur. Since it's the brain is getting affected, patient can have apathy, abulia, irritability, agitation, mania, etc. Very severe, he can go to vegetative state. I told you HIV myelopathy is another disease of the spinal cord, which is due to HIV itself. Most of the time, HIV dementia is associated with myelopathy. How will you diagnose? MRI brain CSF. CSF will demonstrate viral antigen is HIV antigen in the CSF. Treatment is ART, as already mentioned. Okay, so this is about HIV causing damage. But opportunistic infection of the brain is very, very important. So the 2 important cancers or CNS lymphoma and Kaposi sarcoma can occur. If you have to remember about opportunistic infection, there are 5. Toxoplasmosis, Cryptococcosis, Pml, which is caused by JC virus, cytomegalovirus, which mainly causes retinitis, syphilis is neurosyphilis. So toxoplasmosis, cryptococcosis, progressive multifocal leukoencephalopathy, cytomegalovirus, syphilis. At least remember the first one. Of course, TB also can occur. But rather than remembering as such, because each one is going to cause a different spectrum of disease, I have grouped it in different way. Acute meningitis can occur in HIV. Acute meningitis is a separate essay question for you. I'll try to tell few points here itself. If you are doing a CSF, you are able to identify the organism. We call it as a meningitis, acute bacterial meningitis. Most of the time, we will not be having any evidence of bacterial infection or viral infection in the CSF. CSF will be normal. It is called as aseptic meningitis. So HIV itself can cause meningitis, which will be an aseptic meningitis presentation. Why it is causing aseptic meningitis? Because the virus is not causing the meningitis. The immune-mediated injury is causing meningitis. That is why we call it as aseptic meningitis. Usually lasts for 2 to 4 weeks. So acute meningitis could be due to HIV infection itself, where it is an aseptic meningitis. Apart from that, we have the actual acute bacterial meningitis. So acute bacterial meningitis, remember, in the general population also, it is caused by these 3 organisms only commonly. Streptococcus pneumonia, H. influenza, and Neisseria meningitidis. So treated in the same way. Just remember the drugs for meningitis. Ceftriaxone, 2 grams IV OD. Ampicillin, 500 milligram IV Q6 every 6th hourly if the patient is more than 50 years. Vancomycin may be given if staph aureus is suspected. Acyclovir and steroids. So steroids can be given in acute meningitis also, right? So acute meningitis, it may be due to HIV infection, it is an aseptic meningitis, or it could be due to acute bacterial meningitis, like in the general population, caused by Streptococcus pneumonia, H. influenza, and meningococcus. Treatment is ceftriaxone, ampicillin, vancomycin. Okay. Chronic meningitis, this is more important because in the general population, chronic meningitis, always remember one infection, which is tuberculosis, whereas chronic meningitis in HIV infection, it is cryptococcosis. I'm telling this in clinical terms because obviously you are going to become medical practitioners shortly. So if you remember these rules of the thumb, it will be very easy to diagnose patients. When we say chronic meningitis, patient is having symptoms of fever, headache, altered sensorium, neck rigidity, etc. for more than 4 weeks, we call it as chronic meningitis. But chronic meningitis in the general population, think of TB. Chronic meningitis in HIV infected patients or immunosuppression, think of cryptococcosis. It is so simple. So what organism causes? Cryptococcus neoformans or Cryptococcus gattii causes it. CD4 is less than 100 usually. I told you, late in the course of opportunistic infection timeline only CNS is affected. So Cryptococcus is a very late infection. It's a very severe infection. So symptom I told you, fever, malaise, headache, meningitic symptoms are not very common in chronic meningitis. So typical meningitic symptoms like neck rigidity occurs only in 25%. Other symptoms can occur like lung infection, prostatitis, lymphadenopathy, molluscum contagiosum, etc. Diagnosis, your microbiology, India Inc. Fungal culture can do. Cryptococcus is a fungus, remember. So fungal culture can be done, or negative staining with India Inc. Sometimes, rather than the meningitis being affected, a mass lesion can be there. It is called as cryptococcoma. So in the first slide I mentioned you, amphotericin B is a treatment for cryptococcosis. Amphotericin B is the treatment for mucormycosis. Read both of these infections thoroughly because both are 5-mark question. Most of the time you may get a mucormycosis question in your exam because we recently had an epidemic of that. So remember the dose. The dose is slightly similar to that of mucormycosis. So amphotericin B 0.7 milligram per kg daily, or liposomal amphotericin B 4 to 6 milligram per daily with the flucytosine 25 milligram per kg QID for 2 weeks. Continue amphotericin B plus fluconazole till cultures become negative. So amphotericin B plus flucytosine for 2 weeks, followed by fluconazole plus amphotericin B till culture turns to be negative. But secondary prophylaxis is needed lifelong with fluconazole 200 milligram per day. I'll discuss this later also. Okay. So meningitis, acute meningitis, HIV, and as in the general population, chronic meningitis, cryptococcosis, and tuberculosis. Now come to the most important thing, focal neurological deficit. You can see the image difference. I put brain on fire here because the entire brain is affected. Whereas focal neurological deficit, only a part of the thing is affected. So focal neurological deficit in neurology or in HIV patient can present like a stroke, can present with seizure, can present with uniform, the meaning of focal neurological deficit, right? He may have some deficits like a paraplegia or a sensory deficit in one side of the body. Think of toxoplasmosis, PML, CNS lymphoma, cryptococcosis, stroke, Chagas disease, tuberculoma, etc. So toxoplasmosis again is very important. Occurs in 15 to 50% of the patient. Again occurs in late part of the infection, CD4 less than 200. It's due to reactivation of tissue cysts. You know the pathogenesis, I think. From the cat fecus, the cyst is acquired by fecal-oral contamination. Symptoms will be fever, headache, and focal neurological deficit. Seizure can occur. For all focal neurological deficit, think of one term, which is called as ring enhancing lesion. Right? So we have ring enhancing lesion. Single ring enhancing lesion, think of toxoplasmosis. Multiple ring enhancing lesion, think of some other infections. So DD for this will be CNS lymphoma, TB, fungal and bacterial abscesses, the same thing which I told you. Treatment for toxoplasmosis will be again cotrimoxazole. Right? Remember, one double strength tablet daily. Or I told you if cotrimoxazole is allergic, you can give DAPS. But the actual treatment will be sulfadiazine plus pyrimethamine. Just know the names. Sulfadiazine, pyrimethamine plus leucovorin for 4 to 6 weeks. Leucovorin is nothing but vitamin B6 pyridoxine. Sorry, folinic acid. Leucovorin is folinic acid, B9. Sorry. Okay. Coming to PML, Progressive Multifocal Leukoencephalopathy. It is caused by, it's also presents as a focal deficit and seizures. It is caused by JC virus or James Canyon virus, which is a polyoma virus. Again, I'm not going into the detail. How will you diagnose? Diagnose JC virus in the CSF. This is very important because PML, there is no separate treatment as such. Even though it's an opportunistic infection, PML responds to antiretroviral therapy. Okay, stroke, I'm not going into the detail. I told you atherosclerotic cardiovascular disease is common in HIV, so patients can get stroke. Okay, seizure are the same thing. Any patient with focal neurological deficit can present with seizure. I told you PML, toxoplasmosis, of course, cryptococcosis can also occur. But if you see the order of presentation, HIV encephalopathy itself can cause seizure. Toxoplasmosis, cryptococcal meningitis, lymphoma, PML. These are the 5 DDs for seizures. Okay. Other things are not very much important for you, so just I'll briefly go through it. HIV itself can affect the spinal cord. It is called as HIV myelopathy. Occurs in 20% of the AIDS patient. If myelopathy is present, definitely there will be associated dementia. Treatment is ART. It occurs in 3 forms. Okay, if you want to read, just remember the name: bacterial myelopathy, sensory ataxia. Commonly it presents with sensory ataxia like B12 deficiency. If the spinal cord is affected plus nerve, it is called as myeloradiculopathy. The infections causing this will be HIV as such, HTLV, Herpes Simplex, varicella zoster, TB, neurosyphilis, lymphoma. Just know the names. Again, HIV neuropathy. Any form of neuropathy can occur. Diabetes causes ASCVD. So you know very well in diabetes we can have any form of neuropathy, right? Mononeuritis, polyneuropathy, mononeuritis multiplex, autonomic neuropathy. Any form of neuropathy can occur in diabetes. Similarly, any form of neuropathy can occur in okay, so what I mentioned, like diabetes, HIV also is the disease which affects the microvasculature. So any type of neuropathy can occur. AADP, CADP, mononeuritis multiplex, and the classical distal symmetric sensory polyneuropathy, like in diabetes, can occur. So treatment is ART itself, and few drugs can ART drugs can cause neuropathy. So discontinuation of those drugs. And myopathy, it could be due to HIV infection or zidovudine therapy, nothing much. Eye is very important because we have 2 important infections in the eye. One is CNV retinitis. Okay, so it occurs like the neurological spectrum, where the CD4 count is less than 100. It usually causes painless progressive loss of vision. So this is very important because vision loss can occur. In mild cases where loss of vision does not occur, blurred vision, floaters, scintillations, etc. can occur. The diagnosis is mainly clinical. If you do a fundus examination with an ophthalmoscope, you can see perivascular hemorrhage and exudate. The forest fire appearance you would have. So diagnosis is mainly clinical. Just by doing a fundoscopy examination, we can diagnose CMV retinitis. Diagnosing this is very important because it is one important cause of painless progressive loss of vision in HIV patients. So treatments in CMV is a herpes virus group. The treatment is acyclovir family, but valganciclovir oral can be given, or injection ganciclovir can be given. Right? Oral valganciclovir or IV ganciclovir. Second time, if the patient is getting infected, treat with IV phoscarnet. This is one condition where we can give steroids. The second infection in the eye is called acute retinal necrosis or progressive outer retinal necrosis. This is caused by varicella zoster virus. Right? CMV retinitis is one. The second herpes virus which is affecting the the other infections apart from varicella zoster and CMV is Pneumocystis jirovecii can cause plaques in the choroid. Toxoplasmosis can cause chorioretinitis. Syphilis can affect the eye by uveitis. Kaposi's sarcoma lymphoma. HIV itself can cause cotton wool spots like diabetes. Okay. So CVS disease, I told you it's an atherosclerotic cardiovascular disease is more common. So CAD can occur. HIV itself can cause cardiomyopathy. The other conditions causing cardiomyopathy include cryptococcosis, Chagas disease, toxoplasmosis, and some drugs, IFN alpha and nucleoside analog therapy. Pericarditis can occur. It may be due to TB, heart failure, lymphoma, etc. Kidneys kidney HIV associated nephropathy occurs. So it's like a glomerulopathy. We can have microalbuminuria, edema, hypertension. The histological finding will be FSGS, focal segmental glomerulosclerosis. The treatment will be AIT here. This is another condition where we can give steroids. Okay, so that was about the kidney infection. Syphilis can occur. Okay, nothing much about that. Syphilis can occur in HIV. The other genital infections will be vulvovaginal candidiasis, herpes simplex, trichomoniasis, and other urinary tract infections. Coming to small other manifestations. Regarding metabolic manifestations, hope you remember who this person is. He's one character in the Netflix series Squid Game. You can see there is wasting of his cheek and buccal pad of fat. So that is what is called as lipodystrophy. Wasting of fat in face, limbs, gluteal region with the truncal obesity is called as lipodystrophy. It can occur in HIV patients. So what happens is when all this fat gets lysed, there will be elevated triglycerides, elevated total cholesterol, which circulates in the blood, which is going to cause metabolic syndrome and diabetes. So treatment is most of the drugs like protease inhibitors is the cause for lipodystrophy. So treatment is stopping those drugs and giving statins. Electrolyte imbalance is mostly secondary. You may not understand many of these electrolyte imbalances. Just know that hyponatremia may be due to adrenal insufficiency in tuberculosis. Hyperkalemia occurs due to HIV associated nephropathy as due to some drugs. Hypokalemia is definitely due to drugs. I'm not going to deal this in depth. Regarding endocrine, hypothyroidism, hyperthyroidism, Cushing's disease, all these can occur. Need not remember all these things. Rheumatological disease also, it is not very much important for you. Remember one disease, Sjogren's disease is common in HIV, but in the Sjogren's disease that occurs in HIV, we call it as diffuse infiltrative lymphocytosis syndrome. Nothing much. HIV can cause two forms of joint pain. One, HIV arthropathy, which I already told you, which is subacute disease, or Painful articular syndrome is again due to HIV infection itself. It is due to acute. Don't read much. Septic arthritis can occur due to secondary infections. Some drugs can cause osteonecrosis. Hematological disease is also very important because many opportunistic infections like parvovirus B19 infection can cause pancytopenia, anemia, thrombocytopenia, etc. Mycobacterial infection, bone marrow tuberculosis can cause pancytopenia. Bone marrow may be affected by fungal infections and cause all these things. HIV infection itself can cause bone marrow suppression. But the important thing is many of the drugs, zidovudin, these drugs are the drugs which cause bone marrow suppression. I won't deal much about this. So anemia, if you have to remember, one important drug is zidovudin therapy, parvovirus B19 infection, and B12 deficiency. Treatment is correcting the cause. Neutropenia may occur due to HIV itself or due to drugs. Similarly, thrombocytopenia again due to drugs or due to HIV infection itself. This is somewhat important because lymphadenopathy, I told you, stage 1 of HIV infection, we call it as persistent generalized lymphadenopathy. What is persistent generalized lymphadenopathy? Lymph nodes more than 1 centimeter in size in 2 or more extrainguinal sites for more than 3 months is called as PGL. It is the first manifestation of HIV infection. Right? Treatment is ART itself because it is due to HIV. Another important thing is if a patient with HIV presents with lymphadenopathy, always see the CD4 count. Lymphadenopathy with CD4 count more than 200, think of Kaposi's sarcoma, tuberculosis, Castleman disease, and lymphoma. If it is less than 200, it is definitely due to an opportunistic infection like atypical mycobacterial infection, toxoplasmosis, systemic fungal infection, and nocardiosis. I won't deal with the others. Skin, most of the skin infection occur with increasing duration. In clinical stage 2 disease, I told you about seborrheic dermatitis, folliculitis, pruritic papillary eruptions, etc. They occur. But two important skin infections is reactivation of herpes simplex and reactivation of herpes zoster. Right? In this, herpes zoster is very important because it may be the first manifestation of herpes zoster. But contrary to the routine herpes zoster, the herpes zoster in HIV infection occurs in multidermatome. Yeah, so herpes zoster is painless, multidermatomal, can involve other cranial nerves in case it occurs with HIV. Treatment is acyclovir group of drugs. The dose is 800 mg 5 times per day orally for 10 days. Remember the dose for herpes zoster. Acyclovir 800 mg 5 times a day for 10 days is the treatment of choice for any herpes zoster. Herpes simplex causes multiple oral, genital, and rectal ulcers. The treatment here will be acyclovir 400 mg 3 times a day. I have mentioned it wrongly in this slide. It is acyclovir 400 mg 3 times a day for 10 days. Okay, coming to the last part. Coming to the last part, why opportunistic infections should be treated. I told you one important clinical thing or the aim of starting antiretroviral therapy is to prevent opportunistic infection. Again, if the opportunistic infection is present, we should not start ART because it can cause immune reactivation. So the entire endpoint of this class is opportunistic infection should be treated first and only then ART should be started. But for a few opportunistic infection, ART itself is the treatment. There's no specific antimicrobials. Few of the things I mentioned already. PML is one thing. Mycobacterium avium cellular complex responds to giving ART itself. Candidiasis, cryptosporidiasis, and microsporidiosis. The treatment is ART itself. So I told you about the three failures: virological failure, immunological failure, and clinical failure. If a patient gets an opportunistic infection with ART, it is a clinical failure. So opportunistic infections are very important in HIV. That is the entity of treatment of opportunistic infection. But there is another entity called as prophylaxis. This is again an important 5-mark question for you. Because once the CD4 count is falling, we are very sure that patient is going to get some infections. So we are giving some antibiotics to prevent the occurrence of infection. Only for 2 infections, we are going to give antimicrobial prophylaxis. One is Cotrimoxazole prophylaxis for Pneumocystis Pneumonia and fluconazole prophylaxis for Cryptococcosis. Remember, the treatment for Cryptococcosis is amphotericin B and fluconazole, but the prophylaxis for Cryptococcosis is fluconazole. So 2 drugs, Cotrimoxazole and fluconazole, are the only prophylactic therapy, and only for 2 infections, which is PCP and Cryptococcosis. Cotrimoxazole, I already told you, it covers most of the infections. So rather than Pneumocystis jirovecii, it also covers Toxoplasmosis, isosporiasis, bacterial pneumonia, and nocardiosis. Nocardiosis causes lymphadenopathy. So apart from Cotrimoxazole prophylaxis and fluconazole prophylaxis, we have isoniazid prophylaxis for latent tuberculosis infection in HIV. I already told you, patients with Cotrimoxazole allergy, we give dapsone 100 mg OD. But since Cotrimoxazole is a very, very important drug, there's a procedure called as desensitization. So Cotrimoxazole is started in the low dose and gradually the dose is increased. So vaccines may be given, including COVID vaccine, and some other general hygienic measures can be followed. So this is what I was telling about the Pneumocystis carinei prophylaxis. We call it primary prophylaxis when the infection has not occurred. We call it primary when the infection has not occurred and we are giving the drug to prevent the infection. So the dose will be 1 double strength tablet OD. Right, 1 double strength tablet per day. Secondary prophylaxis, patient has already got the infection and we are giving it continuously. So what are the indications for primary prophylaxis? CD4 count less than 350 or clinical stage 3 and 4 is the indication to start. When will you stop primary prophylaxis? When CD4 count becomes more than 350 for at least 3 months, we can stop PCP prophylaxis with Cotrimoxazole. But secondary prophylaxis, we again, it is given after successful treatment for PCP. It should be stopped after 6 months of CD4 count more than 350. Remember these terms. The second prophylactic therapy is fluconazole. There is no primary prophylaxis for fluconazole, but I told you about secondary prophylaxis. After treatment of amphotericin B till cultures become negative, after that fluconazole 200 mg is given till CD4 count becomes more than 200 at least 6 months. Okay, this was the thing. Steroids in AIDS, one is iris, severe infections, severe CMV retinitis, oral candidiasis, esophageal candidiasis, we can give steroids. So despite so many technical things, if we have to remember one thing from today's class is HIV, there are 2 things, HIV, 2 seroforms, HIV1 and HIV2. If you remember the AIDS defining illnesses and the opportunistic infections, you will have a clear picture as for whom we have to test for HIV. We test using a 2-test strategy or a 3-test strategy, mainly with ELISA test for antibodies. Any patient who is tested positive for HIV should be treated irrespective of the clinical staging and irrespective of the CD4 count. The first line of therapy is TLD regimen, tenofovir 300 mg, lamivudine 300 mg, dolutegravir 50 mg. Treatment is lifelong, and you have to watch for any failure of treatment. Failure could be a virological failure, immunological failure, or clinical failure. Clinical failure means the presence of opportunistic infection. And the systemic manifestations can be classified as the manifestation due to opportunistic infection, manifestation due to drugs, or manifestation due to HIV itself. So that's how we summarize it. So respiratory system, the 4 important opportunistic infections are bacterial pneumonia. It is treated like in the general population. Streptococcus pneumonia, H influenza. Treatment is with 3rd generation cephalosporins and macrolides. Tuberculosis treated in the same way, but ATT should be started prior to starting ATT to prevent the occurrence of iris. Pneumocystis pneumonia, treatment is Cotrimoxazole for 1 double strength tablet BD for 5 days, followed by secondary prophylaxis till CD4 count becomes more than 350. If in severe infection, we can give steroids also. Mycobacterium avium intracellular complex, ART plus ethambutol, amikacin, and clarithromycin. In CNS, chronic meningitis, think of cryptococcosis. Treatment is amphotericin B plus fluconazole. Again, secondary prophylaxis of fluconazole should be started when cultures, CSF cultures are negative for cryptococcosis, and prophylaxis is continued till CD4 count becomes more than 200 for 6 months. PML is due to JC virus. It can cause seizures, focal deficits. Treatment is ART itself. Toxoplasmosis again causes a ring enhancing lesion and focal deficit. DD will be a tuberculosis or a CNS lymphoma. The HIV manifestation itself will be HIV encephalopathy, occurs in stages: asymptomatic, mild neurocognitive disorder, and severe AIDS associated dementia. Treatment is ART associated with myelopathy. CNS lymphoma is again a differential diagnosis. GIT, think of oral ulcer, presence of oral HSV ulcer or oral candidiasis means the patient is going to progress to AIDS. But esophageal candidiasis is an AIDS defining illness. Chronic cryptosporidiosis, chronic isosporidiosis, they are AIDS defining illnesses treated with Cotrimoxazole. I didn't deal with multisystem infection. Multisystem, always think of histoplasmosis, coccidiomycosis, Kaposi sarcoma, salmonella, and HIV wasting syndrome. These are my references. So some things would have been excessive for you, but during my lecture, I would have tried to cover many of the things which are important for your exam point. Like I would have touched many points of meningitis. I would have touched some points of pneumonia. I would have touched some points of HIV pathogenesis. So these may help you in some answering few of the questions. Any doubts or discussions, you can ask me. Or we'll stop the class here.
Sir, I have one doubt, sir.
Okay. Who's this?
Hello.
Hello.
I'm Syed Hafiz, sir. Hello.
Okay. Ask.
Sir, in all these opportunistic infection, is it possible to come before HIV diagnosis, sir? Like they have not been diagnosed with HIV and still they come up with
yes, depending on the CD4 count, because we usually diagnose patients with HIV in the clinical stage 3 or 4. So patients with chronic diarrhea, patients with unexplained weight loss, or tuberculosis, only then we diagnose HIV usually. So they occur only when CD4 count falls below 200. But there are a few infections which can occur with CD4 count more than 200. One important thing is Pneumocystis Pneumonia, right? It occurs even with CD4 count more than 200. Another common infection is herpes zoster, recurrent skin infections like dermatophytosis, molluscum contagiosum, right? Seborrheic dermatitis. So these are a few manifestations which can occur even before severe infections occur. So whenever you are seeing such patients, for example, multiple molluscum contagiosum or a genital molluscum contagiosum or a extensive dermatophytosis, a painless multidermatomal herpes zoster virus, or a pneumonia, interstitial pneumonia diagnosed to be Pneumocystis Pneumonia. All these things you have to test for HIV, right? So these are some places where infection occurs before HIV. Your question is a valid question. Sometimes the tuberculosis also can predate HIV diagnosis. Many of the time we diagnose HIV in a patient who is in treatment for tuberculosis. That's what I told initially. Any TB patient test for HIV. So infections can occur before HIV also. That's why if you know what infection occurs in HIV, you can do HIV testing for that particular patient.
Okay, sir. Sir, one more doubt, sir. If there is a recurrent pneumonia case, will the normal treatment affect the HIV status of the patient, sir?
Actually, pneumonia is caused by bacterial. Recurrent bacterial infection occurs in HIV infection, but we are treating only the bacterial infection. It is not going to affect the HIV.
Okay. Thank you, sir.
Any other doubts? Okay, if there are no doubts, we'll close this class. Thank you for your listening. This will be uploaded in YouTube. You can refer it anytime. I'll share the slides also.
Thank you, sir.